My talk today will be about approach to refractory IBD. In this talk, I'll talk about some definitions, and then we'll talk about the mimickers of refractory disease, and then we'll talk about the predictors of disease severity. I guess the data on drug sequencing was amazingly covered in the previous session, so I'll just pass through these slides, and then we'll shed a light on some of the new modalities in IBD treatment. So starting with case for Crohn's disease, Mr. M is a 27-year-old gentleman with fistulizing Crohn's disease diagnosed in 2015 on a clinical background of bloody diarrhea and occasional abdominal pain. He was treated initially with course of steroid followed by azathioprine. Then 1 year later started on adalimumab, but then he was switched to ustekinumab due to immunogenicity to adalimumab. Seen in our service in 2018, so we decided to do disease reassessment and we did colonoscopy. The colonoscopy showed inflamed terminal ileum with stricture. The colon was fine and the biopsy showed a moderate chronic active inflammation in the TI. And we did also MRE, which showed progression of the disease, which involved more ileal lobes proximally. At this point, we discussed this case with the colorectal surgery, and the plan was to go for laparoscopic ileocecal resection electively, which was done in 2019. And the surgical biopsy showed severe chronic active transmural ileitis. The plan at that time was to optimize the azathioprine dose and to start him on infliximab. In late 2020, the patient presented again with flare, with frequent bowel movement, and the colonoscopy showed multiple ulcers at the new terminal ileum compatible with rotigreet I4, as you can see in these pictures. We did TDM, and it showed high antibodies and undetectable drug level, and he was switched to vedolizumab Q4 in combination with the azathioprine, but he's again symptomatic, and the plan to start him on obadasitinib. So what do you think? Is it refractory disease at this stage? By definition, refractory IBD when the disease is not responding or losing the response to all the classes of the licensed immunosuppressive and biologic therapy. And in refractory Crohn's disease, additionally, the disease must be not amenable to surgery. And in case of perianal Crohn's disease, it is when there's a failure of at least one surgical intervention and one anti-TNF. So what we have as a predictors for disease severity in Crohn's disease, we know that when the patients need steroid at the time of the diagnosis, or when we diagnose a patient at an early stage, or when the location is ileocolonic with perianal and upper GI involvement, and from the genetics, when there is no 2 gene mutation, we know that the patient will have more severe and complicated course. What about the need for surgery? We know also that the patient who have jejunal, ileocolonic, and upper GI involvement, and obviously if the behavior is penetrating and structuring, and the smoking, as well as extensive and deep ulceration by endoscopy, and we mean by extensive when there is more than 10% involving at least one segment of the colon, we mean by that the extensive ulceration. All of these can give you a hint that this patient will need surgery at some point. Okay, so before we label patient as having refractory disease, what we have to keep in mind. One, you have to, whenever you have symptomatic patient, you have to confirm the disease activity by objective parameters, whether it is CRP, fecal cal, plus endoscopy, plus or minus imaging. Two, you have to not to give up the medication easily. So whenever you have a chance to optimize the drug and obtain TDM, please do. Three, and it is really important thing to think of any treatable conditions like infection, And I'll mention in the bacteria side, C. diff, viruses like CMV, protozoa like Giardia. Also, it is really important to think about sexually transmitted disease like chlamydia. Also, keep in mind that your IBD patient is like the other population and other patients, so it may come with other entity like drug-induced enteropathy, including NSAID and mycophenolate. And also, it is important to keep in mind, especially in patients with history of ileal resection, bile acid malabsorption and SIBO. It is also important to keep in mind medication non-adherence. And in one study, the medication non-adherence in patients with IBD can reach up 20%, and it is higher with the oral and topical formula. So you have to visit the history again and make sure that the patient is taking the medications regularly or not. Lastly, and it is really important thing to keep in mind, when did you start the medication? Is it when the significant bowel damage has been already happened or not? For example, if there is fibrotic structure is already there, you don't expect that the medication will work on that. So you have to send the patient to surgery and then reuse the same agent. Don't give up that agent and call it failure. Okay, what about when we are done with all the mimickers of refractory disease and we already know that the patient have refractory Crohn's disease? What surgical options we have and what medical options we have. From the surgical side, we know that we have a structuroplasty to be used for structuring Crohn's disease, especially in the small bowel or the upper GI involvement, and it is preferable than the going for resection, as the short bowel syndrome is a risk there. And when it is a Crohn's disease in the colon, it is always preferable to go for segmental colectomy rather than total colectomy or proctocolectomy. And also keep in mind that endoscopic dilatation with CRE balloon is always an option there whenever it is amenable to endoscopic intervention. What about the medical options? I'm sure that most of us face this scenario at least once or twice in the clinical practice, where the patient already used all the biologic and he is not a good candidate to be sent for surgery at this point because he is malnourished, needs nutritional support, and he is also have heavy inflammatory burden, and you have to downstage the disease. So what to do? In this study, they tried to reuse the infliximab in patients who already failed infliximab and adalimumab. And guess what? Regardless of the mechanism of failure, whether it is intolerance, PNR, or secondary loss of response, the infliximab was able to recapture the response in about 40 to 60%. So I guess it is a good chance and good opportunity to go for in a patient like this. All IBD patients need psychological support, no doubt of that. But when a patient reaches refractory stage, he's really in need of psychological support because, he has a negative impact of the multiple treatment failures. He has the realization that the disease outcome might be not desirable, and he is already exposed to so many medications, including opioids, and he's also stressful by the ongoing symptoms. Moving to a second case, patients with ulcerative colitis. Ms. S is a 21-year-old lady with diagnosis of ulcerative pancolitis. She's obese with BMI of 44, diagnosed at the age of 12, and clinical background of bloody diarrhea. She was treated originally with adalimumab, but it failed, and then we switched her to infliximab, and she did well initially. Upon the transfer to our service, she was already having ongoing symptoms, and we did at that time TDM, which showed subtherapeutic infliximab level. So we increased the infliximab to 10 mg per kg, and she achieved remission initially. Later on, she had again symptoms of flare in terms of bloody diarrheas, like 3 to 4 times per day, and CRP was high. Unfortunately, that happened during the pandemic of COVID-19, so we didn't have a chance to do endoscopy or TDM, and we decided to go for ustekinumab. She did well initially, and then unfortunately, again, she presented with another flare in terms of bloody diarrhea 14 times per day. Stool for C. diff was negative, and the FLIC-SIG showed myo-3 disease, and the biopsy was negative for CMV. At that time, we started her on tapering dose of a steroid, and we discussed the case in the IBD MDT. The option either to go for tofacitinib or to go for surgery. The patient preferred to go for medical treatment again, and she started on tofacitinib, but that failed, and eventually the patient sent for surgery. So what do you think, refractory disease or not? I guess it is so refractory disease, and the predictors for disease severity in ulcerative colitis include extensive disease at presentation, proximal disease extension after index presentation, younger age, presence of BSC, longer disease duration, and steroid-dependent disease. Just keep in mind that the patient who present in early stage, in early age, and presenting with coexisting BSC, those are the patients that you expect they will have proximal disease extension at some point. I'll just go through these slides because it was covered amazingly in the previous sessions. So whenever we talk about positioning and sequencing, we have to talk about VERSITY trial, which was published in 2019 and showed superiority of vedolizumab over the adalimumab in ulcerative colitis in both clinical and endoscopic parameters. And then in 2022, CView, it was negative studies where it showed no difference between ustekinumab and adalimumab in patients with Crohn's disease. And then very recent, we heard about the sequence trial, which compared between risankizumab and ustekinumab in moderate to severe Crohn's disease, and it showed superiority of risankizumab over the ustekinumab in both clinical and endoscopic parameters. This was also mentioned in the morning session, so I'll not spend time, but again, it showed superiority of the ustekinumab over the vedolizumab in patients with the Crohn's disease when it's used as a second-line therapy. But in UC, there was no difference between the agents you used. Okay, I guess you will hear about this abstract in details in the upcoming UEG after 2 weeks. So this UK data include about 13,000 patients, and it confirmed what we already know, that the vedolizumab is the winner in ulcerative colitis when it is used as a first line. It is again the winner when you use it as a second line after a failure of the anti-TNF. It is really important to mention that anti-TNF shows similar effectiveness when it is used as a first line or after failure of vedolizumab in case of ulcerative colitis. As you can see here, the vedolizumab in purple color showed superiority over the other anti-TNFs. And when it's used as a second line, again, vedolizumab in blue color showed superiority over the infliximab and adalimumab as a second line in UC. What about in a Crohn's disease? The results was not that exciting. It is what already know. Infliximab was superior to adalimumab in case of perianal Crohn's disease, and non-anti-TNF biologic like ustekinumab and vedolizumab were superior to anti-TNF agents in case of delayed loss of response or intolerance. Moving to the last section in my talk, we'll just shed a light on some of the new modalities in IBD. So tacrolimus in UC, tacrolimus is not a new drug, but it is not widely used in case of IBD. So in one study used oral tacrolimus in case of moderate to severe UC in extensive colitis, and the clinical response rate was about 55% in 2 weeks. And we know that the concerns in using tacrolimus is the immunosuppression in immunosuppressive and biologic patients, about the safety, and this patient is already immunocompromised. What about if we add tacrolimus to this stage? So in this case, another study was done, and it showed that it is safely and well tolerated, and the remission rate achieved in 40% of the patients. What about in case of topical tacrolimus and in case of proctitis? In one study, topical tacrolimus and proctitis showed a clinical response rate of 60% at 4 weeks. And I can say that using topical tacrolimus can save the patient a lot of switching between biologics. So it's worth trying a topical tacrolimus before you switch the patient, at least to induce the remission. Moving to the laparoscopic appendectomy. Starting with the PASSION study, it was a prospective case series of 30 patients used in treatment of refractory ulcerative colitis patient, and it showed clinical response rate of 30% at 12 months. It is exciting result, and we are awaiting to hear more about the RCT's result. We have the ACCURE and the ACCURE UK trials ongoing. Hyperbaric oxygen therapy, the concept of using 100% oxygen is to increase the tissue oxygen saturation, and by that you will modify the pro-inflammatory cytokines and you will increase the tissue growth factors. The initial studies showed benefit in both Crohn's disease and ulcerative colitis, but these studies had huge selection bias. And then another study was published in 2018. It was like a proof of concept study. It showed that using hyperbaric oxygen along with the steroid in patients with acute severe UC result in a clinical remission of 50% at day 5. Fecal transplantation, it was done till now 4 induction studies and 1 maintenance study. The meta-analysis of the induction studies of total of 140 patients showed a statistically significant clinical and endoscopic remission rates. What about the maintenance study? We have only 1 and included 31 patients who already achieved the clinical remission after using the fecal transplantation. The primary endpoint in this study was not achieved, which is the clinical remission, but the secondary outcomes, which is the endoscopic and histological remission, it was achieved. So to wrap up, before you label a patient with refractory IBD, you have to think and rule out all the treatable conditions. Don't give up your drug easily, and when you have a chance to obtain TDM, please do and optimize the drugs. Always in these cases of the refractory diseases, the MDT is the right answer, and please involve the psychiatry to support your patient. We are still waiting to hear more and more about the sequencing and positioning of the drugs. A lot of promising modalities are on the way, so please stay positive. Thank you.